Hi, I'm Christine Glastonbury, and I am a neuroradiologist, and I love head and neck radiology. And I am delighted to be part of the Radiopedia course this year. I am actually originally from Australia, but as you can tell from this outrageous accent, I've been living in the US for quite a while. So before we get started in the next 30 minutes of talk, what I want to do is make sure that you have a couple of things with you. So if you need to pause and come back, do that. But you're going to need to have an iPhone on hand or a Galaxy, whatever. And you're going to need to have a glass of something, the beverage of your choice. Oh, and also you need to have clean hands, which we're all pretty good at doing at the moment, given everything with COVID. So if you have all those things with you, I want you to come on my interactive lecture journey for the next 30 minutes as we go inside the oral cavity. So the problem with oral cavity imaging for a lot of people is really that the anatomical landmarks are a little complex, and that's because we had very complex mucosal surfaces that are opposed to each other at the time of imaging. This makes things a little difficult for us because these tumors hide. So they hide not just because the mucosal surface is complex, but they also hide because the tumors are often very similar in density to soft tissues on CT imaging. And also when you're doing CT imaging, there's a lot of artifact to be had when people have dental amalgam. When you're doing your CT imaging, you've got to remember to use bone algorithm at all time. And as with any time you're trying to stage a cancer or look for recurrence of a cancer, you've got to be very careful with the nodal disease that you see with oral cavity malignancies because they're frequently very small and pretty subtle. So yeah, look at that artifact. This is one of the problems when you do CT, which in the same patient on MR can be crystal clear and things are pretty easy to look at. But let's start trying to understand some of those mucosal surfaces. So I want all of you to take your glass of whatever beverage you have. I've got coffee here, but whatever you have. And I want you to take a mouthful and I want you to swish that in your mouth. Don't gargle it, but just pretend it's kind of mouthwash, whatever, and swish it in your mouth and kind of get a feel of that. Okay, now you can swallow it. And I want you to imagine that what you were just swishing in your mouth was blue in color, and it has now colored the mucosal surfaces of your mouth in blue. And I think when you think about it like that, it's a little bit easier to understand some of the mucosal surfaces. And specifically that you'll note that there are mucosal surfaces over the bone, the gingival surfaces. We have the retromolar trigone back here. We have the buccal mucosal surface that's usually opposed against the teeth and against the gingival mucosa. And then we have some sulci to be aware of. So let's move a little closer to this and understand some of it. So sometimes when you're doing your CT imaging, you'll see these crazy dense structures in the mouth. And it kind of looks like, oh my goodness, do they have some really strange osteoma? Well, these are usually comestibles. These, in other words, this is food. And most often this is chewing gum. Well, why am I showing you chewing gum on imaging? I'm showing it so that you can start to appreciate that if something is wedged in there, just in that mucosal aspect, it can push the mucosa away and you can start to go, oh, that's right. When I look at the oral cavity, the buccal mucosa is pushed down flat normally against the teeth and against the gingiva of the mandible and the maxilla. Well, it is usually chewing gum, except of course when it's tobacco, when this patient came in for their head and neck imaging with this humongous wad of tobacco. I don't know what they were thinking, but there you go. And you take it out in this patient and you can still see a little air where that chewing tobacco used to be. And you can appreciate now how you have mucosal surfaces against each other on CT imaging, which can make it hard to see a primary and hard sometimes to understand what surgeons are talking about. So there is this really cool imaging technique, which you may have heard of, that was first described by Jane Wiseman, a fabulous head and neck radiologist, and that's known as the puffed cheek technique. And that is really getting a patient to take a breath hold and hold it in their mouth and blow their cheeks out. And you can do that right now. And if you do that, you can start to understand how these mucosal surfaces appear. So it's a really nice technique if you have, for example, buccal lesions or a lesion right back in the gingivobuccal sulcus or in the retromolar trigone. It's a very nice technique to push the surfaces away and understand where the tumor is extending. So in this patient who has a history of the right buccal squamous cell carcinoma that you cannot possibly see on this T1, this is the same patient on the post-GAD imaging, and you can see how their cheeks are blown out, and I do not routinely do this when I'm doing MR. It's a lot harder for a patient to blow their cheeks out for 5 minutes. But you can see here this very small T1 squamous cell carcinoma of the buccal aspect of mucosa of the oral cavity that's now standing out there because of air. There's another trick you can do with MR, though. You can actually put gauze inside the patient's mouth and put that between the tumor and the rest of their mucosal surfaces, and it looks black on all MR sequences because it's generally got a lot of air in it, but that has the same effect on MR imaging. So let's go back to that coronal puff cheek imaging, and you can see in blue where the buccal mucosa is here. And if you look at it, here is the maxilla and here is the mandible. Now, the buccal mucosa lines the buccinator muscle, buccal meaning cheek, and hence buccinator is the cheek muscle, but this is your buccal mucosa. Here is the gingiva overlying the alveolar portion of the maxilla and the alveolar portion of the mandible, which is just that portion of bone that holds on to the teeth. But the buccal mucosa is contiguous with that gingiva at the superior and the inferior gingivobuccal sulcus on each side of your mouth. So let's look at this gentleman who comes in with a left buccal squamous cell carcinoma as part of his history. It's always nice if you get a history with oral cavity tumors of where the primary lesion actually is, because they are readily missable unless you have such beautiful enhancement as you do in this patient, where you can see the tumor in the coronal plane and the axial plane. Again, a little air pushing it away makes it a little easier to appreciate that this is the lining of that buccinator muscle where the primary tumor is. And here's that little air in the coronal plane coming back at this level here. And here's our buccinator muscle. And here is the primary malignancy, which has a tendency, obviously, to spread laterally. It's going to spread laterally out into the soft tissues in most cases. And this one was completely resected on all the nodes. Levels 1, 2, and 3 were negative. Well, what about this patient here? She has a left cheek mass also. And if I look at the coronal and the axial plane, you can see this asymmetric fullness. Now you compare that to the right side in this case, and you can see this soft tissue that is going to be spreading out laterally into the soft tissues because that's the direction of soft tissue that it can spread into. And you can see the air gap here is making it a little easier to see some dental amalgam that's not really getting in the way much. But as you would expect, these tumors can also spread superiorly and inferiorly along the course of that buccinator muscle. Now I'm going down a little lower because I want to show you something in this patient. This was a ridiculously small ipsilateral node, which I couldn't possibly have called positive myself on imaging. And this node immediately behind it, lateral to that submandibular gland in level 1B, it's still small. It's probably not quite a centimeter, but it is a little irregular. We call this concerning because we have a high degree of suspicion with these tumors, and these nodes are frequently taken as part of the surgical resection of the primary tumor because of the high tendency for metastasis. And this was, in fact, metastatic disease with extranodal extension, and metastatic disease was actually present in both of these nodes at surgery. So buccal squamous cell carcinomas are those tumors arising from the mucosa that spans the maxilla and mandible and lines the cheek muscle, the buccinator muscle. So these tumors tend to spread out laterally into the soft tissues of the cheek, but can also spread superiorly and inferiorly along that buccinator muscle. And nodal disease is typically to levels 1B, 2A, and 1A. So if we look at this buccal mucosa again in the axial plane, another great puff cheek axial slice. And what I want to move to now is the retromolar trigone. So I want you to grab your finger. I know everybody has a finger there. They better be clean before we start this. Well, it's your own mouth anyway. So I want you to put your finger in there and go to that area behind the last tooth. Now, either you've got 8 teeth on each side of the mandible, or you've had the wisdom teeth out and you've got 7, but go to that soft tissue area right behind that last tooth. That mucosal surface there over the bone of the mandible is known as the retromolar triangle. You can see this patient has had their wisdom tooth out on that side, and this is actually a huge buccal node just from inflammation after they had extraction of this tooth. Okay, so let's think about that space, the retromolar trigone. What we're talking about is a mucosal surface of the bone over, or it's really the bone of the posterior aspect of the mandible, but we're talking about tumors arising from that mucosal surface. So think about that, and I'm going to get you to think about it again, because now I want you to put your finger back into that space and feel the junction there from the mandible going up to the maxilla. And if you feel that ridge of soft tissue going up, think about the potential of a tumor traveling up that ridge from the retromolar trigone right up to the maxilla. And that's what always makes me think trigone is not a good term. We should really think about this like a retromolar pyramid, an RMP, which would make a ton more sense to me. But you need to understand that the tumor can spread up that mucosal surface. And when head and neck radiologists talk about it, they'll talk about this little space area here, which is known as the pterygomandibular raphe. The buccinator inserts onto this and the pharyngeal muscles insert onto that. And people will talk about spread of tumor up the pterygomandibular raphe, but they're really talking about the soft tissue ridge, which is connecting the posterior aspect of the mandible, which is the retromolar trigone, to the maxilla. So in this patient, this is a 69-year-old woman who actually has a left retromolar trigone tumor. And this was actually missed on the radiology report. And part of the reason it's missed is because it was just called an oral cavity tumor. And, you know, sometimes it's really hard to see. And this is truly her slices. I'm showing this because this is the reality of imaging. Head and neck can be really hard when you throw in dental amalgam on top of everything. But there is subtle asymmetry here between the left and the right. And this is the primary tumor. And you can see how hard this is. We're going up a little northwards, and it is traveling up that soft tissue ridge up towards the maxilla here. But you can see that a lot of the head and neck squamous cells don't enhance that much. And it looks very similar to the adjacent soft tissues. But now once it's spread back onto there, it can also spread anteriorly. And I want to show you this patient, a similar left retromolar trigone tumor. Again, here's our retromolar pyramid. Don't forget it's going to travel up that ridge towards the maxilla. So here we can see on our axial image, gosh, you know, if you can't see this, I'm not that surprised. At least we were told this patient had one. But if I come up a little higher, you're starting to see the asymmetric loss of fat planes. So look at the right side. Here's our buccinator muscle, our buccal fat pad behind that. And you can see the complete loss of fat here. And that's one of the tricks to look for these lesions. When you can't find the primary, start looking for loss of normal fat spaces. But this is coming up that retromolar pyramid and also coming anteriorly along that buccinator muscle on the left side here. And that's one of the ways that retromolar trigones like to spread. So it can be amazing how big these tumors can be on scans, and we miss them. And frankly, it's a little embarrassing at times when we see reports, because once you know it's there, it's always really, really obvious. But they start here, come back, and then travel upwards, keep going back towards the mandible, or go anteriorly here at the body of the mandible, go anteriorly here along the buccinator muscle. So let's look at more of some of our mucosal aspects. So we have our puff cheek here. Now this patient they don't have food in their mouth or a comestible. What you're looking at here is this is actually the patient's dentures in here. And with the dentures left in, you can see how you very nicely delineate where the mucosal surface is of the maxillary gingiva. This is the maxillary gingiva, the mucosa overlying the alveolar portion of the maxilla. So if you look at that in the coronal plane, you have maxillary gingiva here and maxillary gingiva here, and this is continuous with palatal mucosa here. So this is the mucosa overlying the hard palate. So yep, you're going to grab your finger and you're going to feel that, how you go from gingiva to palatal mucosa. And remember that tumors can spread the same way that your finger is moving along the palate now. In the sagittal plane, we think about it coming back this way, and notice that again is contiguous with the mucosa over the soft palate. Well, the soft palate is part of the oropharynx, and squamous cell carcinomas do like to arise here, but tumors arising from the hard palate are more likely to be salivary gland tumors than squamous cell carcinoma. And this is such a case. This woman has a left palatal mass. I always go to coronal images, and I also look at sagittal, but to me, coronal is the most helpful when I'm going to look at the bone detail of the palate. And of course, I always want to have bone windows when I'm looking at, you can see this beautifully well circumscribed lesion. This is the same tumor. The patient also got an MRI. You can actually see there's intact cortical bone here. The fat signal here of the maxilla is preserved in this patient. There was no bone erosion here. And this small lesion was an adenoid cystic carcinoma of the maxilla. It didn't have any perineural invasion on pathology or evidence of perineural tumor spread on imaging. Now, this is quite a larger lesion in a gentleman, and you can see you've got a lot of remodeling going on here of bone at least. And our next worry is not, is it just remodeling, but is it actually destroying the bone? And in this case, you can actually see it going into the maxillary sinus from the hard palate, as well as involving the maxillary gingival mucosa in this case. So this is an erosive hard palate mass. It's a pretty big looking lesion, but some of the remodeling would suggest it's actually a low-grade tumor that's been there a while, which is what it turned out to be, a low-grade neoplasm with lots of remodeling as well as erosion. And this patient, unfortunately, could not have this whole thing resected because he also had other comorbidities. But you can see, look at this remodeling on the CT. And the CT is really my favorite to really understand the remodeling, even though the MR gives you a pretty good idea. One of the things to remember anytime you have hard palate lesions, particularly because they're minor salivary gland most often, is to look at the greater palatine canal, which is the highway for these tumors to spread along the greater palatine nerve to the pterygopalatine fossa. So most hard palate masses are minor salivary tumors. You really want to have coronal imaging, whether you're doing CT or MR, to understand, is it remodeling or going into the palate? Is it going into the maxillary sinus? And then look very carefully on all your images for evidence of perineural tumor spread. Okay, so let's move on now to the mandibular gingiva. We've just talked about the maxillary and the hard palate. Let's come down here and look at the mandibular gingiva, which is again the gingival lining, the mucosal lining over the alveolar portion of the mandible. And I tell you, it's really hard sometimes to see these primary lesions. And there is one there. It's not enhancing much. And, you know, you can kind of hallucinate that we do have asymmetry of the landmarks of the floor of the mouth here. But goodness gracious, this is a super hard case, whether on axial or coronal plane, to see this. And it really helps to have some history with it. But one of the things I want you to remember, particularly for gingival, but really for all oral cavity lesion, is when you do a CT, you must look at bone algorithm. You need to look for evidence of cortical erosion and spread into the marrow, which is critical for decision making as far as, are we going to have to do a marginal mandibulectomy, which is just taking out a short segment here, or do a whole segmental when we're going to take a whole portion of the mandible out and reconstruct. So don't forget the gingival tumors go to bone. You're going to look for erosion. You're going to look for marrow infiltration. And once again, with all of these tumors, you're always looking for these 1A, 1B, and 2A lymph nodes. So now I want you to move a little now from talking about the gingival aspect of the mandible. Remember, this is the external gingiva, and then internally is gingiva as well. And I want you to think about not the oral tongue. You can see it's up here. I want you to think about the floor of mouth here. So I want you to get that clean finger and once again, put it underneath your tongue and feel the floor of the mouth and feel what that is like. And of course, because that's difficult, I want you to get your phone out as well. Put your phone up there, turn it onto a selfie view, and take a look with your mouth open, your tongue up, and look at the floor of your mouth and take a look and see what's going on in there. And really start to understand those mucosal surfaces of the floor of mouth and how it is separate from the oral tongue. Because certainly on imaging, it's really hard to understand that at times. So now you can take your finger and your phone out of your mouth, take a selfie if you like on the way back. You can email it to me later. And now I want to look at that anatomy of the floor of the mouth because it's really critical that you understand that before we talk about oral tongue tumors. So here we're going to do an axial plane through the floor of the mouth. We're down through here, through that body of the mandible. And here we are in the axial plane. And the mylohyoid is this sling. Some people call it the levator ani of the floor of the mouth. It's really holding up all the structures in the floor of the mouth. And it is this kind of smiley face sling of the floor of the mouth. And this is what it looks like on your axial plane of your MR or your CT. The sublingual gland is going to be tucked in here, anteriorly tucked up into the mandible itself. Now, paired on top of the mylohyoid are the geniohyoid. So these are going from the geniotubercles anteriorly back to the hyoid bone, and they're small paired muscles. But sitting above them are the big fat genioglossus muscles. And these also insert on geniotubercles above those for the geniohyoid, but come back and really insert into and form much of the body of the tongue. And you can see that the left and right are separated by this fatty septum. On imaging, you can see it beautifully on CT or on MRI. Now, this kind of semi-lunar shaped muscle here you see it on the other side, is known as the hyoglossus. And I kind of think of it as the arms coming out to hug the tongue. And the hyoglossus is a really good landmark to get super comfortable with because of the neurovascular relationships. So medial to the hyoglossus is the lingual artery and the ninth cranial nerve supplying the tongue. Lateral to this, now remember it's a sensory supply, lateral to this, we have the lingual vein and the lingual nerve. And of course, that's the mandibular division of the trigeminal nerve, which we know as V3, as well as the hypoglossal nerve, which is supplying the muscles of the body of the tongue. And tucked in with this is the submandibular duct. The duct, or the drainage of the submandibular gland, comes in this way to the undersurface of the tongue. So we think about those landmarks when we look at this patient here and, oh, there's something strange going on with the left submandibular gland here. Here's the normal on the other side. It's bright on T2 and there's a dilated duct here. Well, there's a dilated duct here because there's something going on in the floor of the mouth. So we go back to our anatomy and we understand that the submandibular duct is tracking down here with the lingual vein and nerve and the 12th cranial nerve. And what we're seeing here is a floor of mouth tumor that is obstructing that duct, which is not an uncommon presentation of floor of mouth squamous cell carcinoma. Now, you can imagine there's going to be a lot of duct obstruction in this case. One of the problems with floor of mouth tumors is they have a tendency to grow into the bone. And in this case, clearly through the bone onto the outside. You don't need to have bone algorithm windows to tell you there is clearly bone involvement here, but you're going to get them anyway to describe the full extent of bone destruction in this case with respect to the teeth, so the surgeon can plan from where to where they're going to need to do their segmental mandibulectomy. So floor of mouth tumors tend to burrow downwards towards the mylohyoid, and they burrow anteriorly and laterally into the bone. You need to have bone algorithm windows. They can be subtle, small tumors in the anterior floor of mouth that are really difficult to see on CT. But if you see an obstructed submandibular gland, yes, absolutely look for calculate, but also be suspicious that there is a tumor there. Now, fortunately, these are pretty easy for most clinicians to see. Now we're going to move now to the last of our tumor group that I think is really important to talk about, and that's the oral tongue tumors. And often these are much easier to understand with the clinical image than just looking at the CT or the MR. Most of these tumors arise from the lateral or the undersurface aspect of the tongue. And you can see in this diagram in this patient here, pretty nice to see on MR. And I do have to tell you that I think MR is a lot easier for a lot of these tumors because, as I said, with CT, they don't always enhance much. But something that is arising from the lateral aspect of the tongue here, remember we're in the body of the tongue rather than the floor of the mouth. This is a little easier to see on CT. This one has pretty moderate enhancement. I always get coronal plane images. You can see the ulceration here. And what you're looking for with the coronal particularly is to see if there is down deep invasion. And you can see on this axial imaging the asymmetry of the structures of the floor of the mouth. And it's really hard to understand on this side where the hyoglossus might be. So again, go back to your landmarks and don't forget the mylohyoid, the hyoglossus hugging the tongue, the genioglossus, and then your neurovascular bundles of the floor of the mouth. So these tumors can be nasty. They have a tendency to arise from the lateral aspect. They have a tendency to invade downwards, and that's why you must look carefully at your axial and coronal images. And if they don't go down, then they can go into bone. Also beware that these nodal groups have a tendency to miss one. So you'll go from 1 through to level 3 and miss out level 2A. This is not uncommon with oral tongue tumors. So I'm going to finish with some tips for oral cavity tumor imaging. You need to know the staging. Pull the table out, follow the rules, and it's pretty easy. But notice this DOI here that you'll see throughout the oral cavity staging. This is depth of invasion, which is a pathological marker of the distance below the basement membrane that the tumor has invaded. It is a pathologic finding, and these are the different levels they measure pathologically. You cannot measure that by imaging. By imaging, you can measure tumor thickness, but where it's endophytic, it's going to be narrower than the DOI, and the tumor thickness is going to be greater than the DOI if you have an exophytic tumor. We measure thickness, pathologists measure DOI, but true staging requires DOI. And here's an example of how that works. This is a case, a woman with a right lateral tongue tumor. Again, pretty easy to see on MR. I said MR is much easier if you're able to do MR. I find it much easier for tongue tumors. You can see this lateral tumor. I measured it out, 1.58 centimeters in greatest diameter. There's no node disease here. So this looks like a T1N0 tumor. The pathology comes back. Yep, we're concordant, negative nodes. Great, the DOI is 6 millimeters. And so this is now moved, because the DOI is greater than 5, into the T2N0 group. So what does need to be in your report as the radiologist? Staging is important, but I've just told you this component can only come from the pathologist. Your job is to describe everything that you can that will allow the person managing the patient to give an accurate stage. All of these tumors, by and large, are resected. So the job you have is to describe the entire extent of the tumor, or what we often call tumor mapping. All of the extent of the tumor that will allow surgical resection, or will give them the information that will allow them to do this. And then when you've done the entire tumor mapping, including looking at bone algorithm for CT and describing marrow invasion, you're going to look for lymph nodes, remembering that these nodes are often small. It is not uncommon to have skip nodes with tongue tumors particularly, and extranodal extension, which is supposed to be a clinical feature, is not uncommon in oral cavity malignancies as well. So I want you to think about that carefully for staging and for resection. What is the information I can give the surgeon or the oncologist managing these patients? So that's what I wanted to share with you today. I really wanted to help you to understand the complex mucosal surfaces of the oral cavity. These tumors can be very, very difficult because they hide, they look similar to mucosa on CT. Don't forget to use bone algorithm and be careful of those small lymph nodes on your report. And I'd like to really thank you very much. I'd like to raise what's left of my glass to you, and I wish all of you and your colleagues and family the very best of health. Thank you so much for listening.